Well, good morning, everybody. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. So excited to have you back for our fall season. We have a number of excellent speakers lined up. So today we'll get started with some reminders, some logistics, and then introductions before we get into the meat of things. Next week, I'm very excited to be hosting our annual CAMR lectureship, which typically features a talk in endocrinology. And we will be hearing from Dr. Michael McClung, giving the talk Osteoporosis 2024, Practical Issues and Conundrums. So be sure to join us in person here at St. Vincent at 8:00 a.m. next Tuesday. And he will also be speaking in person at Providence, Portland at noon on the same day, next Tuesday. So Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Center. We are always available to watch live on Teams. So welcome to those of you who are out there. We are often here in person on Tuesday mornings at St. Vincent. And sometimes our speaker is also live at Providence Portland, typically at noon on Tuesdays. You can always learn these details in the weekly invite, so please pay attention there. You can also earn CME credit by being here live in the room, by watching virtual live, or by watching a recording of the event. And that recording is also available at the same link as the weekly Grand Rounds invite. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions you have for our speaker, and I will mostly field those as time permits at the end. And now to introduce today's speaker, we are joined by Dr. Eric Ryan, a faculty nephrologist at OHSU. Dr. Ryan completed his undergrad and medical training at University of Colorado, and then residency at our own Providence, Portland. While he was there, he was quite active in curricular development and in medical education, including his international trip to Uganda. Dr. Ryan then completed his nephrology fellowship in 2023 at OHSU, and his clinical interests include critical care nephrology, as well as renal disease and pregnancy. Dr. Ryan has received teaching awards as a resident, a fellow, and was most recently the Faculty Teacher of the Year for the OHSU Nephrology Fellowship. So I am feeling lucky to learn from him today. Thank you, Dr. Ryan.
Great. Thanks for having me. It was really fun when Dr. Powell reached out to have me come talk with you guys. I'm assuming there's familiar names from Prov Portland in the chat. I don't have it here, so if you guys are there, it's nice to see you. If you ask questions, please let me know who they're coming from. It'd be good to reconnect with people. I don't have any specific conflicts of interest. I'm employed entirely by OHSU. This is not a dialysis talk, but I do round it for Fresenius and DaVita units. Our organization has contracts with them, but we're not paid directly by them, and I don't have any financial involvements there. So our learning objectives today, although I said this is not just about EGFR, we will in fact review chronic kidney disease staging and talk about EGFR to some degree. And then I was hoping to drop a couple knowledge pearls about prognosticating and kind of how you can calm patients down a little bit sometimes when they get this big scary diagnosis in their chart. We're going to talk about mineral and bone disorder in CKD, which will hopefully be a great and maybe less nuanced talk than you're getting for osteoporosis next week. So this is a nice timeline for that. We'll talk about anemia in CKD, kind of where it comes from and what we do about it. Some recent data about RAS inhibition in CKD that was published a year ago. We'll talk about kind of my approach and some pearls about blood pressure management in advanced CKD, as well as everyone's least favorite thing, which is when to give bicarbonate to anyone. And then if time allows, I was going to talk a little bit about the somewhat recent transition away from race-adjusted EGFR, kind of what we got right in that, what we got wrong in that, and then kind of my personal thoughts there. So I started medical school in 2013. So I guess now that is kind of long ago, but not that long ago. And it was news to me that this didn't exist forever. It might be news to some of the younger trainees that this is actually a pretty new thing. So this amazing Technicolor CKD grid that we all know and love and hate was actually founded in 2012. And before that, there was very minimal guidance in terms of what to do with these patients. The reason it was designed was not necessarily based on like any like outcomes data or any specific criteria. There's nothing magical about your eGFR being 31 versus 29 or 61 versus 59. This was designed kind of as a quick reference in the primary care setting to highlight folks who maybe we should be paying attention to their kidney function, especially with creatinine formulas being standardized and with eGFR being more available. This was a nice tool. But like I mentioned, this does have some pitfalls. It's somewhat arbitrary. The cutoffs are meaningful to a degree, but not necessarily. I would argue, and I was talking with someone before this lecture, that the nomenclature is not at all patient-oriented. And it's very scary to have a chronic disease stage 3 labeled in someone's chart. So I think there's some room for improvement there. It's a very static chart and a very static labeling system. It's for folks who are at their baseline and don't have any changes recently. It's not always applicable, which we'll talk about on the next couple of slides. I would argue a lot of times it's overzealous. It labels people at a higher risk and can lead to interventions and worry that they don't necessarily need. And on the other hand, sometimes it's underzealous. For some young folks, they can be in that green area, but they're actually in pretty rough shape and do need attention. So we can talk about that a little bit. So anytime I get a chronic kidney disease consult, the first thing I like to do after kind of assessing where this is from, which we're not going to be able to get into today, is kind of where is their kidney disease going? So this is a patient that I saw in clinic a couple weeks ago. His name's Jerry. He lives up in the Dalles. He used to be a farmer, and he's like, tough living, super active, up the coast farmer who just cannot sit still. He retired from farming at 85 after his wife really got on his back about climbing on tractors and how dangerous that was. He got bored and he picked up tennis. Now he plays tennis a couple times a week. He's got a history of one drug hypertension. He's on amlodipine that he's been on for like 15, 20 years. His blood pressure has been okay. And then on the right there is a former Prov resident who exercises more than he used to, but still not quite enough. And has, kind of the metabolic syndrome, central adiposity, not great A1C, not diabetic. This actually is my residency graduation photo. If you walk down the hallways in Prov Portland, there's this amazing, big timeline of all the residents who have been there. That picture may or may not be there. But these folks are sent to me for the same reason. They both have an eGFR of 34 when calculated with their creatinine clearance, and they both have I would say moderate albuminuria at 177 milligrams per gram. So what do you do with these people? Both of them are this CKD3B with some protein. And so it's tempting to say, they're both the same person. So the thing that I like to use is this kidney failure risk equation. I don't know if anyone's familiar with this. But what this is they took, thousands and thousands of patients with known kidney disease, and they measured their indices at the beginning, namely their albuminuria, their sex, their age, and what their eGFR is. And then it just plotted them over time, and it created a formula for you. So you can take any patient that you have, and you can throw them into that formula, and you can see what happens. You used to have to go to kidneyfailurerischequation.com or Google it or whatever it is. Very, very recently, it's in Epic. You can do .kfre2 or .kfre5. And it will tell you these patients' risk at 2 and 5 years of becoming eligible for needing a kidney transplant or potentially needing dialysis, so having an eGFR under 20. And as a reminder, these patients, Jerry and our unnamed Rick, both have an eGFR of 34. They have an albumin creatinine of less than 300, but still present. And so they're both firmly in the very scary red box in our amazing Technicolor chart. But when you go through and you plot them out, you get two totally different pictures for these people. Jerry, who as a reminder is 91 years old, has a 2-year risk of those kidney outcomes of less than 2% and a 5-year risk of less than 6%. So Jerry is the type of guy you can walk into the room and you can say, hey, Jerry, if I had 100 of you in a room, only 6 of you would have severe kidney problems in 5 years. And we've all met Jerry, we all know the type, and he says, well, I'm planning to live for 20, so what about that? You say, well, I don't know if that's a reasonable goal, Jerry, but I think at 96, you will still have healthy kidneys. Versus Rick, who has a totally different presentation. Rick's got a 6.5% risk of being on dialysis in 2 years, so 1 in 16 or something like that. And at 5 years, the risk goes all the way up to 18.8%, so 1 in 5. I'm hopeful that Rick has more years left in his life than Jerry, but I am worried for Rick because he does need more care to his kidneys. And so, I'd just like to highlight that treating patients all the same and looking at that chart is a great starting point, but there is some more nuance to it, and this KFRE is a very nice tool for that. And the reason for that is, chronic kidney disease comes from all sorts of stuff. If you go to any dialysis unit or you come to my clinic most days of the week, and you'll see the vast majority of patients with advanced kidney disease have some combination of two things, which is hypertension and type 2 diabetes. And those things take time to build up. At the lower end of the spectrum, like neonates aren't really eligible to have hypertensive kidney disease because they haven't been around for very long. They're not really eligible to have diabetes build up quickly because they haven't had it for long enough. And then similarly, at the older end of the spectrum, if folks were going to get severe manifestations from their diabetes or from their uncontrolled hypertension, most of them do it before they become. So I think really contextualizing your patients and thinking beyond that chart and using that tool is beneficial. And it can really help you stratify, who's at risk for having a progressive chronic kidney disease related to their underlying medical conditions versus who has 91 years of mileage on their kidneys and is actually, frankly, quite healthy. So moving on beyond kind of just some basic prognosticating stuff, getting into kind of our topics. The first thing I wanted to talk about was mineral bone disease and chronic kidney disease. And the KDIGO definition, which is a international work group that does kidney related recommendations and guidelines, is the systematic disorder of mineral and bone metabolism due to CKD that has either one or a combination of the following. So abnormalities in calcium, phosphorus, PTH, or vitamin D metabolism, abnormalities in bone turnover, mineralization, volume, linear growth, or strength, which are not things that we can easily test for. You can get DEXAs, that's fairly easily. Bone biopsy is not super easy. And I would argue waiting until someone has a fragility fracture or develops a brown tumor like this is probably not the best course of action. And then it's blocked by this picture here when I remodeled from Mac to Microsoft, but vascular calcifications is that last one. If you do abdominal x-rays of folks that have had really horrific mineral bone disease from advanced CKD for a long time, you can see their abdominal veins like light up. Every now and then we have to tell folks that they can't get a transplant because they basically turned their abdominal vascular system into bones. Also poor form to have that happen. So mostly what we're talking about here is secondary hyperparathyroidism. So the constellation of lab findings that we're looking for in these folks is generally they should have a low, if not normal calcium. If they're hypercalcemic, that's probably not due to their chronic kidney disease. That's more down the primary hypertension route, which would be, or the primary hyperparathyroidism route, which would be a great thing to ask your endocrinologist about next week. Their PTH should be up pretty obviously. They should have a low vitamin D level. And the phosphate at this stage can kind of do what it's going to do, but very commonly it's going to be high. I'm sure we all remember like bashing our heads into a desk for something like this during step 1 or step 2, or maybe even our medical boards. It seems every time that I look at it, it gets more complicated and has more acronyms and things that I don't understand. I remember when it just talked about phosphorus and calcium and PTH. When I was in medical school, FGF23 or fibroblast growth factor 23 was like kind of the new player. And now we're adding in all these other things like sclerosin and klothos and rank L ligands and all that kind of stuff, which is nice to know about, but I think not super relevant in terms of what we're going to be doing for our primary care patients. So instead, I like it to break it down into the things that we can control and things that we can augment and kind of the pathway through those things. And so the first thing that I like to think about in these folks is their vitamin D metabolism, specifically their calcitriol levels. Kind of as a reminder, calcitriol is the activated form of vitamin D. That can happen kind of a couple of ways. We can get vitamin D through cholesterol is getting metabolized via the sun, which in Portland between like now and maybe, I don't know, April or Easter, we're not going to see a ton of, versus vitamin D intake. And then it has to be activated, which predominantly happens in the kidneys. And when folks develop chronic kidney disease, that activation of vitamin D is one of the very first things that starts to fall behind. So we don't run into a lot of problems with chronic kidney disease until EGFRs are like under 20 or 35 or something like that. But we do see mineral bone disease pretty early in CKD3, certainly by CKD3B. So, calcitriol, we don't have a great way to hijack our kidneys into activating vitamin D better. So this is just one of those things we can give people. And indications for giving calcitriol, it gets kind of like this nomenclature, this idea of being very complicated, but there are very straightforward guidelines. These are from the KDIGO guidelines, which again is that international nephrology work group. And basically, if you've got folks who have chronic kidney disease stage 3 or 4, so an EGFR under 60, and they have this constellation of lab findings, you should consider offering them calcitriol. So they should have a high enough level of inactive vitamin D, because that's easier to give people. They can eat more of it. You can supplement it for cheaper. It's not a prescription. And if the problem is they just don't have enough building blocks, you can just give them those building blocks. But if their vitamin D level is intact, over 30 is the number people pick. So I've seen people pick 40. And if their PTH is towards the high end of normal for CKD3, which is 70, or if it is above normal and over 110 in CKD4, and if they're not hypercalcemic, you can start those folks on calcitriol. So you can start them at a low dose. It's 0.25 micrograms daily. I've seen some patients who, for example, take their TSH like 2 times a week because they don't need a ton. You can give them half a microgram twice a week. It doesn't really matter. So you can start them on a low dose calcitriol, and the goal is to get the calcitriol into their system. You'll notice that there isn't anywhere on here that involves checking an activated vitamin D level. There isn't data to suggest that we should be treating to a activated vitamin D level. The goal is to get calcitriol into their system, and we know that long term, like years and years or decades even, bone health, when you get these folks on calcitriol, they do have better outcomes. So you start them on calcitriol, you check labs in a month, and you say, am I causing any problems? Namely, are they becoming hypercalcemic, which is the reason to stop therapy? Did I drop their PTH like too low? So is it now under 35 for CKD3, or is it under 70 for CKD4? And if their FOS is elevated, then you control their FOS. But again, I think setting a proactive goal of getting calcitriol into these folks early and just making sure you're not causing problems is the right approach to take. And commonly in advanced CKD, the way we manage these patients is to kind of set our reference range of how abnormal we're willing to let them be. And the goal is almost never totally normalizing things, which we'll see as we move forward. If you're an algorithm person, this is the algorithm you could look up. We're not going to go through it. You could ask for the slides if you're interested in seeing them, but these are the KDIGO algorithms, and there's this kind of flow chart through it. The next one that we do after vitamin D, which I think is a little bit more complicated, is tackling patients' phosphorus. We know that long-term hyperphosphatemia is associated with things like osteoporosis, fragility, fractures. At severe stages of chronic kidney disease, it's associated with awful things like calciphylaxis. So we really want to make sure that our patient's phosphorus is controlled. Again, not normalized, but controlled. And the reason we do this second is that I think it's a bit more complicated and a bit more patient involved. So where does phosphorus come from, and how do our kidneys manage it? So phosphorus comes all over the place. There's 2 main types of phosphorus. There's organic phosphorus that made itself out in the world and that humans are kind of made to be consuming. And then there's inorganic phosphorus that I would argue humans are not necessarily made to be consuming. So places that we find organic phosphorus, like leafy greens, nuts, potatoes have phosphorus in them. Red meats particularly have a lot of phosphorus. And frankly, we don't absorb all that much of the organic phosphorus. It's a bigger molecule that doesn't move through our gut as well. And so only 40 to 80% of that gets absorbed depending on the person's degree of chronic kidney disease, how their gut's working, when they ate, what they ate combined with, that kind of stuff. Inorganic phosphorus is where the problem comes. And like everything in the American diet, the problem comes with heavily preserved foods and heavily processed foods. And inorganic phosphorus is absolutely everywhere. So it's in basically anything that's got a preservative. It's like wildly variable how much of it is in Coke. Like Diet Coke, for example, has a ton of phosphorus. Coke Zero doesn't. Like some root beers do, some others don't, but it is in a lot of brown sodas specifically. And inorganic phosphorus we absorb very, very readily. And the issues with having high phosphorus levels are, again, it can decrease effective calcium, which is bad for bone health. It can increase PTH secretion, which can lead to rapid bone turnover. It interferes with vitamin D. The goal ranges are here, again, noting those are not stone cold goal ranges. So if you're going to counsel anyone on managing their phosphorus or managing their hyperparathyroidism, I've never found it useful to give patients a big list of foods of what they can and can't eat, because they're going to try to make sense of it and they're going to try to remember it, and I don't make sense of it and I can't remember it. So instead, what I tell patients is you should limit things that come out of a bag, a box, or a drive-through window as much as you can, and foods that just kind of are what they are, so namely ingredients, fruits, vegetables, meats, or things with shorter labels, are generally going to have a lot less phosphorus in it. And if folks can stay away from those heavily processed foods, mostly they can kind of do what they want, and their phosphorus level will be at least manageable with meds, if not pretty normal. If your patient absolutely has to have foods that they don't prepare themselves, Trader Joe's actually doesn't use any preservatives in any of their food, aside from like citric acid and some other thing that is not phosphorus containing. It's like rosemary extract or something like that. So if you have patients who, for financial reasons, or they don't know how to cook, or they have, a disability or something where they aren't able to prepare their own food, if you have to point them somewhere, Trader Joe's is actually pretty good. I do not have any stake or any stock in Trader Joe's. I just think it's a good tip to send your patients to. And if you can't get there with dietary modifications, which for a lot of folks in early CKD, they probably could get there. That's when we start everyone's least favorite thing, which is phosphorus binders. And so when to initiate these, again, it's not super complicated if their phosphorus is above the goal. So for CKD3, we want their phosphorus between like 2.5 and 4.5 or so. CKD5 is where we want them to be 3.5 and 5.5. So again, tolerating a certain degree of abnormality. And there's a lot of phosphorus binders you can pick. I do think in the primary care setting, or when you've got a patient with advanced CKD in the hospital, it's totally a fair game to start these without a nephrologist. A lot of them are not super complicated. So every phosphorus binder works by having some molecule that complexes with phosphorus in the patient's gut. So they need to eat it with food, and then it binds the phosphorus, and then they excrete it when they go to the bathroom, and they don't absorb it. And picking a phosphorus binder, you just have to pick what that thing is, and what side effects you're willing to tolerate from it. So for example, calcium itself is a very good phosphorus binder, and everyone loves taking Tums. So if patients have a moderately, very modestly elevated phosphorus, they can identify which one big meal a day they eat. They don't have a ton of money, or they're underinsured. You can have them take a Tums or two with their biggest meal, and that's a totally valid way to control someone's phosphorus as long as their calcium's not climbing. Sevelamer, I highlighted the lamer part of it. It's not a very strong binder, but it does seem to be everybody's go-to. The reason being it doesn't really cause other problems. It's not leading to hypercalcemia. It doesn't have some of these scary heavy metal associations that older binders used to have. When Sevelamer came out, it was kind of a big deal because it was thought to be this kind of binder for the people that works very well. So you can give it to folks that have a high calcium. You're not going to make it work. It is pretty expensive. Folks do need decent insurance for it. And when you hear patients talk about, their handful of horse pills that they're taking with every meal, almost invariably, they're talking about Sevelamer. So if you've got someone who needs one or two with a meal, Sevelamer is reasonable. If you've got folks who have to take 3 or 4 of them with a meal, really focus on diet control and maybe think about something a little bit stronger than Sevelamer. Lanthanum exists. I don't know how often it's given by anyone other than nephrologists. It's a big chalky pill that people chew. Some people don't mind it. Some people really hate it. It's for some reason expensive despite being extremely old. And then there's a bunch of other ones. There's iron-based binders that I don't suspect anybody in primary care is really prescribing super commonly, but you can know they exist if you see them pop up on someone's med list, specifically like a dialysis patient in the hospital. Almost never will those patients be on oral iron. It's much more likely to be a binder. Here's a chart that you guys can reference that has kind of side effects and advantages and disadvantages if you want to. So that's kind of a lot. I like having summary slides. So this is just the hits for mineral bone disease and kind of early to moderate chronic kidney disease. So if you have to pick one thing and patients say, I have early kidney disease, what does this mean for me? Mineral bone disease, particularly if you've got a postmenopausal woman with like CKD3B, is probably the thing that's most likely to cause an impact for them. And treating it early is shown to be beneficial, specifically with things like calcitriol. We compensate by hyperparathyroidism and elevated FGF23 levels until the eGFR is around 30. So you won't be seeing overt hyperphosphatemia, but you will still be seeing those long-term effects. So think about it early. The goal level to get someone's inactive vitamin D is around 30. And then again, for the phosphorus and PTH, we're tolerating slightly higher levels because for every patient with advanced CKD, we allow them to be a little bit abnormal. Calcitriol is good, use it early, but don't make them hypercalcemic. And just know that algorithms exist. If you Google KDIGO mineral bone disease, you'll find like a lot of very straightforward good algorithms for it. The next most common thing we see in all of our patients with advanced CKD is anemia. It's virtually everyone, as we'll show on the next slide. There's a lot of different factors. The one that gets labeled the most is, that your kidney makes EPO, and if your kidneys don't make anything, then they're not making EPO. In dialysis patients and really advanced CKD patients, that's probably true. Earlier in disease, that's probably less true than we used to think. Our patients get a lot of lab draws. I remember when I was in medical school, it was like for every 12 lab draws you do, it's a unit of blood. In terms of like when they take the blood, they flush it, they discard it, they draw it. It's like a whole thing. And so patients who are on dialysis or in the hospital or have advanced CKD are getting lots of lab draws. Their production level is already low. So iatrogenic anemia, I think, is underappreciated in these folks. And then there's increasing knowledge of this molecule called hepcidin, which I like to kind of think of hepcidin as like backwards ferritin. And it binds iron, but it makes it totally useless. And so we see hepcidin levels go up in folks that have chronic kidney disease because our kidneys get rid of it. And so in people who don't get rid of much through their kidneys, they hang on to hepcidin and it makes iron useless. And then also a state of inflammation will do it. The kind of evolutionary thought behind hepcidin is that it's what goes up when we have bacteria in our blood to kind of limit iron's availability to them. And in anemia for chronic kidney disease, as with all of our CKD metrics, the goal is not to make someone's labs look normal. If you've got a patient with CKD4 and their labs look normal, like something's probably wrong there. The goal is to improve their quality of life while not causing adverse effects down the road for them. And just because someone has chronic kidney disease doesn't mean they can't have anemia from any number of other things. So these folks still do need their colonoscopies. The data would suggest that, especially for patients on dialysis, they're like way, way, way behind on colonoscopies. Partially because they already are so medicalized that they don't get colonoscopies, partially because there's some reservations about, futility of finding cancers in patients who have advanced chronic disease, the safety of doing procedures on them, even though none of those things have shown to be true. But colonoscopies are important for these patients. They can still be B12 or folate deficient, pretty uncommon, but look for it. And if folks have other illnesses, like if someone's got lupus or someone's got horrible glomerular disease, that's a good reason for their anemia, and you're not going to fix that by treating their anemia. You'll fix it by treating their disease. So our goal in advanced CKD for anemia is to tolerate a level of like 10 to 11. It's kind of where the data has shaken out when you look at it overall in terms of patients like being able to exercise if they want to, not being horribly orthopnic, not exacerbating their heart failure symptoms, and not doing scary stuff like driving their hemoglobin to 13 and causing hypertensive strokes. So hemoglobin should be low in these people. They're anemic. They should have a normocytic hypoproliferative anemia, which would let you know just, hey, there's not a stimulus around to make these red blood cells. Here's some data about anemia prevalence through different stages of CKD. As you can see, for stage 4 and 5, you're overwhelmingly likely to have significant anemia. At CKD3, it's still pretty darn present. So the first thing we do in treating anemia is make sure they have the building blocks that they need to make blood cells. If someone could and does have enough EPO around, but they don't have enough iron, it's never going to work. So the indications to give iron are like very, very low threshold. So basically, we want to give folks kind of a relative iron overload. I wouldn't drive their ferritin up over 1,000, but typically over 500 and almost always over 200, especially if you want to get them on EPO. Their TSAT generally should be over 30. And if someone's hemoglobin is under 10, you can also just give them iron for that. The ferritin and the TSAT, I realize, are kind of high levels to transfuse people to. A lot of this is driven by what insurance will pay for EPO. So no one's really said, is a TSAT of 15 versus 25 appropriate, but kind of driving them into the 20 to 30 range is what we do. And so if folks don't have a high ferritin, don't have a high TSAT, and are in fact anemic, should give them iron. IV iron is preferred. I'm sure we've all heard a lot about how we just don't absorb GI iron. In patients with chronic kidney disease, they absorb it even less. So I wouldn't really recommend anyone with CKD 3B or higher getting oral iron. It's just not going to work. And then once you've confirmed they have enough iron, we can just start people on EPO. And so the indications for that are if someone's got enough iron, so they have the building blocks to use the EPO that you're about to give them. If their hemoglobin's under 9, they definitely should get EPO. If it's between 9 and 10, they probably should. If it's over 11.5, they probably shouldn't. And if it's over 13, they definitely should not. I have the carats wrong here. But again, the goal is not normalizing hemoglobins. We don't want to get people's hemoglobin to 13.5 or 14. We want to get it to where they're not super short of breath when they're feeling well and when we have good outcome data. There's a lot of formulations for EPO, and frankly, which one gets used is largely dependent on like what your pharmacy has and what insurance will cover. For dialysis patients, they get short-acting formulations typically because we have access to their blood vessels 3 times a week. For outpatients, like you'll want to get someone started on something that's more of like a 2 to 4 week formulation. And that's something that you can talk with your pharmacist about, and they're very good at helping you with dosing and picking out a formula. So we're maybe halfway-ish through the talk. In residency, I picked up the idea of becoming the person who knows weird stuff about medical history. And then through fellowship, that medical history became even more weird stuff about dialysis units. So these are all pictures from the Dialysis Museum, which is up in Seattle. If anyone really wants to like have a not that interesting, but mildly interesting half day and you're in Seattle, the Dialysis Museum is kind of cool. Seattle actually is kind of the home of outpatient maintenance dialysis. The first place in the world that did it on a routine basis was up there. Started with just a handful of patients that a nephrologist physically would come in and cannulate every night. And that has since expanded to, this worldwide thing. So these are some early dialyzers. In the upper left there is this rotating drum. And so the way that would work was blood would get piped through kind of those tubes that are wrapped around the drum. And there's this big bath of dialysate. And then someone would literally at first sit there and crank this thing and spin it around to get the blood to contact dialysate. And then later they put it on a machine. On the right is a flat plate dialyzer where there's like a ton of like sandwich levels and dialysate in some and blood in the other, and blood would just trickle down and gravity was the source there. And then my personal favorite, someone made this at home. It's a pressure cooker artificial kidney where they like hijacked an old pressure cooker and put a coiled kind of membrane inside of it. And they used pressure and steam and agitation to circulate dialysate while their blood went in and out of this pressure cooker. Which is pretty nuts that someone did that, but it worked actually. And all of these things were kind of discovered or at least pioneered by this gentleman, Belding Scribner, who was up in Seattle. He was faculty at the University of Washington for a long time. And he's got this quote that I really like: a patient with advanced CKD and hypertension is volume expanded until proven otherwise. And so what we know about hypertension is that it both causes CKD and it gets worse in CKD. almost all patients, as they progress towards dialysis, even if they didn't have pre-existing hypertension, will eventually become fairly hypertensive. And the reason for that is very straightforward. As your GFR goes down or you have increased proteinuria, you just aren't able to get rid of your salt and water as effectively, and you become volume expanded, you have a higher total body amount of salt, and you just will become hypertensive. So as GFR goes down, our shift on how to control hypertension for these patients should shift more towards things like diuretics and more, away from things that have other complicated, potentially dangerous mechanisms, which we'll talk about. And also their hypertension gets worse because people start stopping medications. Thiazides, we stop at 30. There hasn't really ever been a robust trial that's shown it's dangerous and that's what we should do. But when they first came to market, it was just kind of this idea that thiazides won't work as well at a low GFR, which is true to some degree, but you can in fact use thiazides at lower GFRs. ACEs and ARBs get stopped at a GFR of 30 or 25 commonly. SGLT2 inhibitors, which have some degree of hypertensive control, get pulled off at lower GFRs. People get nervous about things like spironolactone for good cause. So my approach to hypertension and CKD, there aren't a lot of guidelines about how to do this. So my approach is if someone's got a good non-renal reason to be on a specific drug, I keep that around. So someone's got heart disease or someone's had a heart attack, like I keep their beta blocker around. It doesn't cause problems for their kidneys. I like calcium channel blockers second, unless folks have really significant edema. And then I very quickly start a loop and up titrate it pretty effectively. You do have to tolerate some degree of their creatinine getting worse, but in someone with CKD4, I would argue it doesn't really matter all that much. Like the goal is to keep them from getting hypervolemic, keep them from having hypertensive crises. And if you have to tolerate a creatinine that goes a little bit higher, that I do not think that's going to cause significant long-term damage. For very carefully, you can start spironolactone or an ACE or an ARB. We'll talk about some new ACE-ARB data. And then 5 is where you start doing things like adding on a thiazide in addition to your loop diuretic and really honing in on how you're going to diurese these folks. In folks who don't have another reason for it, I'm not a huge fan of alpha blockers, certainly not clonidine, because you get rebound. Folks have to take it 3 or 4 times a day. It ends up causing more problems than it works, I think. Hydralazine, I think similarly, if it's not taken 3 or 4 times a day, is not known to be super effective. Nitrates, I just don't have a ton of experience with, and I don't use them a ton. They're fine, but they're not something that I reach for. Regarding ACE inhibitors in advanced CKD, this was kind of a data-free zone for a long time. It was just kind of guidelines that we should be stopping ACE inhibitors due to the risk of things like hyperkalemia once people's CKD progresses to stage 4. And finally, about 2 years ago, we got a trial that said, like, what if we keep ACE inhibitors around? Do we cause more damage? Do we cause more benefits? Do we have better hypertensive control? Are people dying? Are they living longer? And so this was a randomized controlled trial. Several hundred people. It's published in the New England Journal of Medicine. And the outcomes were things we care about. They looked at folks' eGFR. They looked at their mortality. They looked at progression to dialysis and how their blood pressure did. And then I think, the other half of folks were more concerned about causing things like hyperkalemic events. So they did look for a lot of safety outcomes. And, this trial for me was really frustrating. Around this time, we had a trial that said, are thiazides beneficial in advanced CKD? And the answer is sure, but probably not, but also probably not dangerous. We got a torsemide versus Lasix trial that we were all excited to show torsemide would be better, and it didn't. It turns out they're about the same. In this trial, we were like, all right, finally, we're going to be able to keep these anti-proteinuric drugs around. Our patients are going to do better. And it turns out they were exactly the same. So if you inherit a patient who had their ACE inhibitor stopped, or if you feel like you're going to stop someone's ACE inhibitor, and you're worried, or if you get asked like, hey, but I'm on this for my kidneys, is this going to cause kidney problems? The answer is probably not. Their kidney is probably going to progress the way it's going to progress. So you can feel okay with yourself that you stopped that medication, particularly if there was a concern. This was the outcomes for worsening GFR, and this is the outcomes for folks needing to go on dialysis. Again, not a big difference there. So you're certainly not causing any higher incidence of kidney disease by stopping these early. But are you helping people? Like, are you preventing their hyperkalemia? It turns out probably not either. So the total adverse events that they used in this paper were kind of crazy. It was things that could not at all be related to blood pressure medications, but they kind of recorded everything. So they had like heart attacks and strokes and headaches and like shoulder pain and ortho stuff. When you go through and look at adverse events that are life-threatening, namely hyperkalemia, or related to cardiac medications like heart attacks and strokes and stuff, there really isn't a big difference. So for hyperkalemic events, the group that had their ACE stopped early, 1% of them had hyperkalemia. In the group that had their ACE continued, 2% of them had hyperkalemia. I would argue if you've got a cohort of patients with CKD 4 and 5 and you follow them for like 36 months and only 2% of them have hyperkalemia, like that's pretty darn good and probably is just par for the course. So big picture, it probably doesn't matter if you keep someone's ACE inhibitor around as they progress through chronic kidney disease. If you've got patients who are reliable, if they're stable, if they've never been hyperkalemic, if they are already on a high dose of a loop and their potassium's running a little bit low anyway, like totally fine to keep it around. And the data would suggest you're not causing adverse effects in those people. But if for some reason you have to stop that drug due to patient concern, tolerance, hyperkalemia, it's probably not worth moving mountains to keep that drug around. A year or two ago, I would like start people on like Lokelma a couple times a week, which is an oral potassium binding agent to like bring their potassium down just so I can keep their lisinopril around for their whatever membranous nephropathy. And these days I'm not doing that. I don't push it as hard anymore. I think the last specific manifestation of CKD we have to talk about is metabolic acidosis. We all know that as CKD progresses, you get a development of this kind of worsening metabolic acidosis that we won't go over. We have some data that's kind of all over the place to suggest what we should do with these folks. The most, I would say, ambitious results are from this trial that looked at what proportion of patients have their creatinine double if you get them started on high-dose oral bicarb supplementation versus not. And this trial would suggest that it would be like malpractice to not have these people on supplemental sodium bicarb. Other trials, when you look at a meta-analysis, are much less firm than that. So we won't go through this, but here's the kind of forest plot. And you can see there is probably a trend towards starting bicarb as it pertains to renal outcomes, but certainly nothing like was shown on the previous slide. So my approach to dealing with metabolic acidosis in folks with CKD, I get a baseline VBG. I don't think you need to do an arterial stick, and certainly not in the outpatient setting. And make sure that there isn't like some other respiratory process going on. It's poor form to label a respiratory process as a chronic metabolic process. And then look at them for contraindications. If someone's got horrible volume sensitive heart failure, probably would not give them a big sodium load every day. If they have tons of edema, they're probably going to stop taking it. If they hate taking medications and they're only going to take 4 or 5 a day, I would not burn one of those 4 or 5 on bicarb. And for a bicarb goal, you'll see different recommendations. Some folks will say, the bicarb should be 16 or over. Attendings will always say it should be old enough to drive. Some people say it should be old enough to vote. Some people should say it should be old enough to drink alcohol. I target a bicarb of 18-ish. I think when you kind of look at all of the different data, that's as reasonable a number as anything. And I'm not a huge believer in totally normalizing lab values in folks. And again, you should counsel them on the sodium load. It is a not insignificant amount of sodium you're giving folks. And if they're really struggling with their dietary sodium intake, like adding a bunch more with bicarb tablets is maybe not the best idea. So that was all of the different manifestations of CKD. I have some content about kind of the race-adjusted GFR stuff. I figured we'd stop if anyone has questions about kind of more clinical things before I move on to more esoteric things.
Great. Thank you so much. Happy to take a pause and field questions. Anything from here in the room?
Hi, this was really helpful. Thank you. I wanted to ask about, you talked about your approach to stopping ACEs and ARBs as the GFR lowers, and you briefly mentioned SGLT2 inhibitors. I was wondering if you could speak a little bit more to your approach to when do you stop, or if you stop, and
Yeah, so I generally don't stop them. The kind of approach that most folks take is if, you shouldn't really start them under an eGFR of like 25, not because anyone's assessed is 25 safer than 20 and is it worse than 30, but just that's what the trials have all done. And I've not seen any suggestion that there's a reason to stop them at a certain level. So I tend to continue them if they're started initially. If they're not doing anything for patients, or if they have like, an event of euglycemic DKA, or a lot of our patients have significant vasculopathy, I have a pretty low threshold to stop them. But I generally don't discontinue them at any specific GFR.
Stupid question. Could you remind me of the common bad endpoints that we're trying to avoid in our approach to the metabolic bone disease? Calciphylaxis is terrible, but it's rare.
Yeah.
What are we trying to do with this complicated regimen?
Yeah, so it's a set mostly premature onset of like osteoporosis, fragility fractures, that kind of stuff. If folks are deranged for long enough, they can head towards like osteomalacia and adynamic bone disease and kind of like more ESRD specific things, but it generally is like osteoporosis type things.
Great. Question from online for the moment then. Patients at varying GFRs, when they see their diagnosis of CKD, will often ask, what can I do? You talked a little bit about diet, particularly pertaining to phosphorus. Any patient education or advice or answer you have when patients are looking for some empowerment?
Yeah. So I think it's tough, and depending on where it comes from. So in someone who's, the most common folks are diabetic and hypertensive, and controlling those diseases is obviously the most important thing you can do. And folks who aren't, but I think could stand to maybe lose some weight or better metabolic health or exercise more, I encourage them to do that. There's a lot of back and forth about like what to do about protein intake in these folks. There's a really good like point counterpoint or differing opinion thing in New England maybe 6 months ago about protein intake in folks with CKD. And the data is all over the place. I think for folks who really want to have like a dietary goal to feel that they're doing all that they can, I recommend that they don't like supplement with excessive protein. If they want a number to pick, I usually tell them like, 0.8 or 0.75 like milligrams of protein per kilogram of body weight per day. So in a 70 kilogram person, that ends up being like 50 grams of protein a day. I think the data is fairly strong that really excess protein intakes can worsen CKD outcomes. I'm not super convinced that a very low protein diet helps, but I tell people don't push proteins, like focus maybe on more of a plant-based diet. Everyone wants to know how much water they should drink. I usually tell people like 1.5 liters or 2.5 liters a day if they really want to set a goal. It realistically won't change anything, but that's what they like to know.
Yes, they do.
Yeah.
Thank you for those tips. Just going to take us back to ARBs for just a moment. Thanks for the trial about those later stages in CKD 4 and 5 and maybe not making as much of a difference. We're often seeing patients more in maybe the stage 3 realm and have all experienced some increases in creatinine or mild hyperkalemia with starting or increasing doses of ARBs. Can you just point out any pearls you want to emphasize for use of RAS medications at those lower or higher GFRs?
Yeah. So the creatinine increase from 0.2 to 0.3 or whatever, or of 0.2 or 0.3 is totally expected. I tell patients that before I start them, especially people who watch their labs. So that's normal and not a reason to stop therapy. And actually, if you look at how folks do in terms of proteinuric benefit and GFR change over time, the people who have that like modestly elevated creatinine response actually do better. It's kind of proof that the drug is working. And someone whose creatinine doubles or goes from 1.2 to 2 or something like that, those are folks that commonly we're stuck stopping medications for. One thing that I think is been really beneficial in the past couple of years, in the big kidney-related SGLT2 study, which was EMPA-CKD, it came out like 2 years ago. They actually had a non-proteinuric arm in that, and SGLT2 inhibitors do improve long-term renal outcomes in patients without proteinuria. So my threshold to like stop an ACE or an ARB and transition to an SGLT2 inhibitor is pretty low these days, especially if someone has other blood control options, like isn't diabetic, isn't floridly proteinuric. Like those are folks who you can use whatever you want for their blood pressure, and if you want to do something for their kidneys, SGLT2 inhibitors are good.
Thank you. I just want to call out from our online audience for some of those dietary questions and patient education. Utilizing our excellent dietitians are a fantastic resource. Let's let you move on to your next content for the bit of time we have.
All right, this one will be maybe a little bit less clinical, but I think is worth hearing about just kind of the big changes that happened several years ago with the way we assess kidney function. So the way we check kidney function is kind of counterintuitive. So looking at the blood to measure how much of something you put in the urine is like kind of by its nature not a great way to assess things, right? So like getting a serum creatinine level to then work backwards to a urinary creatinine clearance is kind of tough. And then when you throw in what is this idea of clearance, that's like even more complicated. It spits out in our EPIC is this weird formula of milliliters per minute per 1.73 meters squared, which is like not a unit that anyone can intuit. So the idea of what clearance is it's how much of blood could theoretically be completely cleared of a substance. So basically it's answering the question per minute, how many milliliters of blood could you take all of the creatinine out of? Which is weird. It's not like what percentage of creatinine is coming out. So it's kind of this odd thing. And we could measure it directly. So what you could do is you could, find a substance that doesn't exist in our body. You could give it to someone. You could measure the concentration when you give it to them. You could measure it at the end. You could remove all their blood from their body, and you could see how much volume of blood there is. That's poor form to totally phlebotomize our patients. So we don't ever measure it that way. And you can measure in the urine. You can check how much creatinine goes into the urine a day, and you can do math. That is the formula you could do if you wanted to. The more intuitive way to think of it is if you go to a party and there's a bathtub full of punch, and someone were to say, how many bottles of Everclear are in this bathtub full of punch? Like you could get there, right? You could calculate, you could measure the alcohol content in the bathtub. You could know how big the bathtub was, and then you could work backwards to say how much Everclear would make that much water that alcoholic. And the formula we'd use is that same one I showed you. And so you can do that. You can measure people's 24-hour urine collection, and you can check how much creatinine's in it, and you can do that math, and you can say this is their creatinine clearance over the last day, and I know that because I measured it. But we don't do that very often. I do it, twice a year, maybe. I'd be surprised if anyone in here has done it in the past decade, maybe ever. So instead what we do is we talk about things like clearance and GFR and eGFR and all this crazy stuff. And so the GFR is that direct measurement of someone's blood. That doesn't happen. The clearance is the volume of blood that is cleared by a substance. That's that 24-hour urine collection plus some math, which doesn't really happen that much. And then the estimated clearance is where you calculate it based on blood. And then the eGFR is where you calculate the creatinine clearance based on blood, and then you work backwards to the GFR, because creatinine clearance and GFR are slightly different, which there won't be a test. You don't need to remember that, but just remember this is like a roundabout way to figure out how well someone's kidneys work. The analogy I make to patients is it's like going to your friend's house and you look at how dusty their floor is and you try to guess how well their vacuum works. Like, it's okay until you learn that like they didn't vacuum yesterday or they threw a party and there's more dust on the ground. So it's not great. So the best we do is we try to make these formulas to go from things that we do know, which is the measured clearance in some patients, to things we don't know, which is the estimated GFR in others. And we do that with formulas. So over time, the first formula we had was this Cockcroft-Gault formula. We all probably heard about it. It was from a gentleman who's now a Canadian pulmonologist. It was his medical school project. And so they took 250 patients. The average one was like my dad, like a 70-year-old white male with kind of early CKD3. And they just made up the female correction. They said, I bet women's kidney function is 15% better or 15% worse at a given creatinine. So a creatinine of 0.85 in a woman is 1.0 in a man. Weirdly enough, that's actually pretty darn close to correct, but they did just make it up. In 1999, there was this MDRD where they used pre-existing data from a dietary study, and they kind of looked at it a little differently and made a new formula. And then in 2009, CKD-EPI came out, which was kind of a meta-analysis of different databases and formulas. CKD-EPI, obviously more patients, more minority representation, but they didn't really look into why, for example, creatinines in patients who self-describe themselves as Black tended to be higher. They just said, maybe the creatinine of 1.1 in a self-described Black person is a creatinine of 0.9 in someone who would describe themselves as white. And so they just threw in that kind of correction factor. Didn't really look into it, but that's where it came from. And so how good are these formulas? They're terrible in general. So these are from the original MDRD study. And this is an ugly plot, but basically every one of those dots is a person. And the farther they are from that center line, the farther their kidney function is from what's reported. And so as you can see, there's folks here who have an actual GFR of 60. It's getting reported as 30. There's folks who are being told they're nearing dialysis and their kidney function is perfect. There's people with great kidneys, or there's people with terrible kidneys who are getting missed. So these are not great formulas at the onset. And there's this issue I think we all heard about back in 2020, switching away from having the race adjustment in our GFR formulas, which again, no one tried to explain. They just identified there was a difference here and put it in their formula. To these formulas that weren't race adjusted. The reason behind that, extremely valid. If you look at who is getting referred for transplants, if you look at who's getting referred to nephrologists, if you look at who is getting transplanted, there are massive racial disparities that they do exist. And the thought was, if we are overestimating kidney function in minority populations, we're sending them for transplants later because their GFR is actually 19 and they could get a transplant, but it's being labeled as 22. And that is responsible for a lot of these differing outcomes. So this is another ugly slide, but the issue that folks had was this bias in particular. And so the average bias for a Black population in the formula that we used 5 years ago was negative 3.7. So again, that's that patient whose eGFR is listed as 22 and they are not appropriate to be put on the transplant list, but their GFR is actually 19 and they should be accruing time. And so that was the issue that, again, did exist and there is that outcome there. And so the first thing that they did is they said, well, what if we just remove the race coefficient entirely and we just treat everyone the same? And so what happened there is this, new formula, which was new when this paper was written. It's not what we use now. And it showed that when you do that, you actually double the bias, but in the other direction. So that same patient whose GFR is 19, it's actually listed as 12, which gets them on a transplant list much sooner, but also their ACE or their ARB gets stopped sooner. They're listed for transplant when their GFR is actually 26, which is not appropriate. So they quickly said, well, that isn't a good formula because we've caused twice the problem in the other direction. So then the new formula, they said, let's make a new formula and we will put data in that doesn't have race adjusters and we'll make a formula that's as accurate as possible for everybody. So the formula we have now that they use here and at OHSU and kind of every major health system is not the prior formula without the racial adjustment. It's a brand new formula, knowing that there was not going to be a race adjustment. And how does this formula perform? Like all of them, not super well. But I think when you look at like how it performs unwell is very interesting. And so in Black populations, the bias is virtually the same. It's just in the other direction. So instead of being a negative 3.7 bias, it's a positive 3.6. And then the bias in non-Black populations went from being negligible 0.5 to negative 3.9. And so the new formula, I would argue, actually introduces more bias to more people. I think there is a valid argument that systemic racism has caused outcomes issues. And if you're going to have a formula that's wrong, having it be wrong in a way that can overcome some of those issues, like I think that's a totally valid argument. And I don't have a vote on which formula we should use. But I just think it's just interesting to contextualize that people who think we now have a better formula or we have a more accurate formula, that just unfortunately is not the case. And I think the interesting thing is that we did have a better formula all along, which is the cystatin C, which I don't know how many of you are familiar with it. Creatinine comes from muscles. Cystatin C comes from every cell with a nucleus. So cystatin C is particularly useful in like bodybuilders or frail old women with low muscle mass or cirrhotics. And it's also useful in everyone. So the cystatin C formula we had prior to making all these adjustments actually performed better for everyone than our new formula does for anybody. So I think, you know, in terms of if you guys really want to, as accurately as you can, using a blood marker, detect someone's kidney function, and especially if they have a, you know, not typical muscle mass. So again, cirrhotics, bodybuilders, frail older folks, cystatin Cs are the thing to do. I think Providence switched to LabCorp, right, for their labs. LabCorp can run a cystatin C. I have no idea if it's a send out, you know, out of the region, but you can get them. I know at OHSU, a BMP costs like $16 to run and a cystatin C costs $18 to run. So they're out there. I think it's something to think about, and just kind of to contextualize the big change that we all made. So that's kind of what I have. If anyone has questions, I'm happy to take them. Looks like we're 2 minutes over, so maybe in person later. This is my favorite quote about kidneys. Yeah, thanks for having me.
Great. Thank you so much.